I'm joined here by a really great group of people. Tim Justice, Tim Madden from Intrinsic. We've got our marketing group here, Kerry Hagan, our CEO. I see his name there. Jason Cobble, who's our head of sales. Oscar Ye, who's one of my co-founders, which means that he has tremendous endurance. The two of us, man, we've been working on this problem for a long time, as we're going to present tonight. But we're really proud of the position that we've brought the technology to and the data that supports its use. I think it was a very, very challenging labor, but I think we understand the disc extremely well as a result of the last 15 to 20 years of design and clinical trial and testing. And I'm not sure, is it the appropriate time? I know that for me to start, can I share my screen?
Yeah, I think so. And also just wanted to welcome Dr. Strenger to this webinar as well.
Hi. Welcome, Doctor. It's great to have you here. So today I really have the pleasure of going over the work of many dozens and dozens of people, both inside of Intrinsic Therapeutics and the clinical and commercial sites that have been fundamental to building the clinical evidence that supports the use of Barricaid in a high-risk population of the lumbar discectomy patients. So it's I founded the company in the year 2000. So this is not a new business. We have always been focused on the same thing, however. We've always been trying to improve the outcomes of lumbar discectomy, particularly in those patients who are at the greatest risk of recurrent disc herniation reoperation. So we started with preclinical studies. We went into prospective studies immediately, went through 2 different implant designs, and it only took us about 8.5 years to come up with a bone-anchored implant. The prior implants were not anchored to bone, and what we realized was it's not anchored to bone, it's coming out. And so just like the annulus is attached to the end plates above and below, the Barricaid implant is securely anchored to one of the neighboring vertebral bodies. And that really was a sea change in the efficacy and safety of the implant. That allowed us to enter into 2 single-arm studies with the Barricaid in patients with large annular defects, and I'll go into that in a second. And that led to our multi-center randomized prospective clinical trial, which we started enrolling in December of 2010. It was a very large randomized prospective superiority study that formed the basis of our approval with the FDA, which came just recently last year. We've made some improvements to the implant since we finished enrolling that trial because we have over 7,500 implantations worldwide, many of those commercial, a large percentage of them under some form of clinical protocol, but many of them not. And so we recognized and learned through the clinical trial that we can make improvements to the device. We've made those improvements, and that's the system that we've just gained approval for just prior to COVID-19 lockdown for the most advanced version of our implant. So very happy to speak about the implant today and the results. Oscar is our head of R&D, and he has been pivotal in the execution of our single-arm and randomized clinical trials. So we have now over 40 publications peer-reviewed on the Barricaid technology in this high-risk population and innumerable podium presentations. This is why I founded the company. This is my mother. In 1999, she'd already had an L4-5 disc herniation, as you can see. She's got a pretty massive L5-S1 disc herniation, so she was really suffering at the time of this image. She went on to have an L5-S1 discectomy. She had an L4-5 and an L5-S1 recurrent disc herniation. So she's been through 4 surgeries by the time that she reached this image. She's been through a fusion since then, 2-level. You can see that before her fusion, she had some pretty substantial disc collapse. She had extrusions at both levels, or protrusions or extrusions at both levels. Her activity was limited quite dramatically. She could walk 100 meters, still even now. She can walk about 100 meters, and then she has to take a day or 2 off. So she was in her 50s when she had her first disc herniation, and it really changed the trajectory of her life. She was a very active outdoor person, and she is no longer. And I think that it's one of the reasons why we've all worked so hard on this, is we've seen this failure in other patients, and our goal as a company is to try to minimize the number of patients that go beyond their primary discectomy, that have a reoperation for whatever reason. This is her AP view, and that, or Uh, uh, so she's had some degenerative curvature prior to her fusion, which I think was part of her pain. So I looked through the literature when we founded the business to see whether or not she was part of the norm. And while discectomy is very successful early on, when you look at population-based studies, there's actually a surprising level of dissatisfaction and reoperation. These are all comer populations. So the Swedes do wonderful national registries, and they did one in spine. They showed that at 1 year, as early as 1 year, almost a quarter of the patients were dissatisfied with their results from their primary lumbar discectomy. The state of Washington also did a massive study. They looked at everybody that had a discectomy, and they showed that there was over a 13% reoperation rate at 4 years, and that trajectory sort of continued on in the finished study, the entire population there again, up to 19% at 9 years. And there's an excellent article actually out of the Washington State Group that plotted the results of relatively large studies over time of discectomy and showed that it followed this curve that went very directly from 8% to 12%, 13% up to 20%. The other thing that was surprising was you would think that for recurrent disc herniation, a simple extruded fragment, that you could go in there and get it out again, and the patients would do just as well as they did the first time. And that is clearly not the case. The results from well-studied or well-studied populations for reoperation show that there's significantly less improvement in terms of everything, really. Patient satisfaction, function and pain scores, there's a significantly higher opiate use at higher doses, and lots more people not working. So the reoperation is nowhere near as successful as the primary operation. If the patient needs a recurrent surgery, they don't do as well as the people that didn't, which sort of makes sense. Our study, and this is the first data I'm showing you from our study, this is the large randomized prospective single-arm study. And if you need to minimize me, please do, so you can see the data. There are many unique factors of our trial. One of them was that we continued to follow patients even after a terminal failure. Terminal failure is any reason why you would fail the 2-year endpoint. In theory, you could stop studying the patient at that point because you already know the outcome at 2 years. We continued to follow these people, and so we got to see the results of reoperation. And just like the published literature, and I think we published this now as well, the reoperative patient population did much worse than their non-reoperative cohort in terms of disability by ODI, VAS leg, VAS back, and a surprising percentage of patients who were no longer working, and time to work loss, everything was worse for the patient population. So the clear message is, when discectomy is great and the patient doesn't need a recurrence, they do really well, or doesn't need a reoperation, they do really well. If they don't do as well and they need a reoperation, they don't do as well. And this is really something to be avoided. This is sort of the dream of any medical device developer, is that there would be this high-risk subgroup that you could target your implant toward, because you can do the maximum benefit with the minimum number of devices used. So as it turns out, there is a subpopulation in the 400,000 discectomies that are done every year in the United States that are at substantially higher risk of recurrence. And those are patients with large annular defects. It's a very good study out of Stanford, Carragher's study, that showed that massive annular defects, or defects that were 6 millimeters or wider, had a much, much higher rate of reherniation and reoperation than patients who had smaller defects. So when he looked at his data, he showed that these 6 millimeter or larger massive annular defect patients had an over 25% reherniation, symptomatic reherniation rate, and an over 20% reoperation rate, whereas people who had small annular defects had a very low rate of recurrence and reoperation. And so our philosophy has been, if we can focus on this high-risk subgroup with the large annular defects, we can maximize our benefit for the minimum possible cost. So these are the people that need the help, and if we can make their results anywhere close to the results of their small annular defect patient cohorts, that's the best possible outcome. So this is the population that we're going to speak about from here on out. High risk, large defect. There's another criteria for the use of our implant. We want there to be a disc that's worth saving. If the disc is completely collapsed, which is a surprising percentage of the incident patient population in disc herniation, doesn't need our implant either. Number one, it's very difficult to get in, and number two, there's not much nucleus left. So we require a disc height, minimum disc height of 5 millimeters. That takes out actually 30 to 40% of the incident patients, and that you see on your preoperative imaging. And then intraoperatively, we've got a series of very simple millimeter by millimeter gradation sizing paddles that you insert with 2 fingers lightly until you start to feel resistance. And as soon as you feel resistance, that's the mechanical width of the annular defect. If it's 6 millimeters or larger, that's a large annular defect. That's the kind of patient that you need to treat. If it's smaller than that, they don't need our implant. You can close, and they likely have a very low risk of recurrence. So we have an intraoperative exclusion criteria. This is our implant. It's a 2-part component. It's actually simple in retrospect. It has a titanium 6-4 grit-blasted self-tapping anchor that is driven into either one of the neighboring vertebral bodies from your standard posterior approach. And that anchor secures an attached flexible polymeric occlusion component. So this is a multi-layered Dacron or PET woven mesh that is stacked up, looped through the anchor, and then sewn back upon itself. It is flexible, so it moves with the disc, and with the spine, it doesn't restrict motion at all. It just stops nucleus from exiting the disc space, from leaving the annular defect. There's a platinum iridium marker that you can see on the X-ray that marks the mesh that you can see it post-operatively, because it's not visible on X-ray or MRI. Otherwise. And then you can see that Ti-6-4 is a really wonderful material, not only for on-growth and strength, but it allows you to clearly see the epidural space and evaluate any recurrence. I'm going to show an image on the right-hand side of one of our biomechanical tests, so you can minimize me. This is our implant in place over a massive annular defect. I believe this is a 10 millimeter wide defect. And we're sending this cadaveric spine through flexion and extension. So it's leaning to the left in flexion, it's leaning to the right in extension. Coming in from the anterior, we were talking just before we started about measuring pressure in the disc space. There's the needle with a pressure sensor in it. And because we had read this article and met the biomechanics expert and believed his 23 atmospheres, what we would do is apply 4 kilonewtons of load in flexion, simulating flex lifting, generate 23 atmospheres plus of pressure, and study the stability of our implant. So you can see those platinum iridium markers shifting to the right in flexion as the nucleus is pushing it toward the posterior, trying to get out, and shifting again to the left in extension as the nucleus sort of watermelon seeds forward in extension. So we don't restrict the motion of the spine at all. We simply move with the nucleus and keep it in place. Our surgical technique is not terribly complicated. I believe we just did a case today. What you do is you do a standard limited discectomy. We encourage you to leave as much nucleus behind in the disc space as possible, because we're trying to preserve the disc and preserve the disc function, preserve its ability to generate pressure once the annular competence is restored. So you clear out, you decompress the nerve root and any free fragments sitting in the annular defect. That's the end of your discectomy. The first step of our procedure is to measure the size of the hole. So you take those sizing paddles and you confirm, number one, that it's 6 millimeters or larger. And number two, we have 2 different implant sizes, 8 and 10. You want to make sure that you implant an implant that is at least as large, if not larger than, and my preference is larger than, the defect that you measure at the time of surgery. We then have an alignment trial that it looks as the exact same profile of our loaded single-use disposable delivery tool. And you use that to confirm that you have the appropriate access and trajectory to deliver the anchor into the target vertebra. And again, you can choose either one. And what I like to say is that there's an imaginary line coming off the bottom of the tool. That's where the base plate of our anchor is going to come out. You want to make sure that that never crosses the end plate, that's always below the end plate. And then we've got our single-use disposable delivery tool. It's a pretty small footprint in your operating room. We like to bring in 2 8 millimeter size implants, 2 10 millimeter size implants. We've got a very small instrument set. You simply tap with a hammer on the back of our delivery tool, and it simultaneously drives the anchor into the bone and the mesh into the disc space. The mesh winds up being seated on the anterior surface, inner surface of the annulus. There's a little nitinol wire that you can see there that's part of the delivery tool that lifts the occlusion component against the opposing vertebral body, and then You remove the tool and you're done. You can see here, there's a little bit of a gap between the posterior wall of the vertebra and the back of the anchor. So we're countersunk by 2 millimeters so that there's nothing left in the epidural space. Takes about 5 minutes in skilled hands. It's probably 15 minutes when you start, just getting comfortable with the technique and we do require more bone removal. So I think it's getting comfortable with the laminar removal. We can be deployed open under microscope or through a tube. My suggestion with a tube is to start with a 20 or 22, get comfortable with the technique, work your way down to an 18. I have seen it done through a 16, but there's no reason to push yourself through that much pressure. It's a relatively large implant for 16 millimeters. So I'm going to turn it over now to Oscar Ye to speak to the results, both the clinical results from our randomized clinical trial, as well as some of the independent commercial registries that have been published.
Great, thank you, Greg. And the formal results of our study were published in the Spine Journal. The first author there is Professor Tomei. Next slide, please. So what I'm going to be describing to you is this randomized control study. This was used as our pivotal study with FDA. As you're probably familiar with different spine studies that have been run with FDA, typically a composite endpoint. We were no different. We actually had 8 different subcomponents, consisting of VAS, ODI, discite, reops, things of that nature. But a couple of things that set our study apart. The first is that we prospectively designed this to be a superiority trial. So while the bar would have been lower if we just wanted to show non-inferiority, we really set out to show that Barricaid could provide a clinical benefit over discectomy alone. And the second unique thing about our study was that we performed the randomization intraoperatively. So you heard Greg describe this higher risk patient population, this population with the higher symptomatic reherniation rate based on the defect size. The sites were instructed to perform their normal limited discectomies, and then they would use those defect sizing paddles that Greg showed previously. And only after they confirmed that these defects were at least 6 millimeters in width, only after that point would they perform the randomization. If it randomized to control, the surgeon would simply close, and if it randomized to Barricaid, they would then proceed with the Barricaid implantation. But so in this way, we were really trying to ensure that we were controlling for the things that we've seen to predict poor discectomy results. So looking to ensure that the defect sizes were controlled between groups, as well as the amount of nucleus removed. Next slide, please. And so these are the primary results that we saw in our study. And what's being shown here in the red curves is the discectomy only group. So again, these patients with these large annular defects. On the left-hand side, you're seeing the cumulative rate for symptomatic reherniation. And the first thing we see is a rather substantial symptomatic reherniation rate, nearly 30% through 3 years. And this was in great agreement with that study that came out of Stanford, which showed over 27%. On the right-hand side, you're seeing the consequence of those reherniations, a pretty substantial reoperation rate to treat those reherniations at over 16% at 3 years. And now if we overlay the results of the Barricaid group, you can see that the device is performing as intended. The device covers that annular defect, and it reduces the risk for symptomatic reherniation. And there you can see on the left-hand side in that teal color, over halving that rate for reherniation. We could see a statistical difference between the Barricaid and discectomy-only groups as early as 90 days. And this significance was maintained all the way through 3 years. And you can see there graphically just that magnitude of benefit being maintained as well. On the right-hand side, again, the consequence of being able to reduce the reoperation rate, the reherniation rate, is that you can save on the number of reoperations as well. Near 60% reduction over 3 years. Again, statistically significant as early as 90 days and maintained all the way through the 3-year period. On this next graph, what we are showing are the serious adverse events. And so in the context of this clinical study now, This is going to be any hospitalization or reoperation that's related to the spine. And you can see plotted here again for the discectomy only group, a pretty high rate at over 19% at 3 years. And overlaid with the Barricaid group, again, nearly having that rate. And so these serious adverse events, these SAEs, they would include for the Barricaid group any potential device complication. And you can see there that there still remains this large benefit. Each reoperation that's performed in the control group to treat a reherniation is itself a serious adverse event. And so really you can summarize the Barricaid story quite simply. Barricaid was designed to reduce reherniation risk. It cuts that in nearly half. It cuts your need to reoperate in nearly half, and cuts your SAE rate by nearly half. Next slide, please. We're often asked, though, that if you do have to reoperate in a Barricaid patient, is it more risky? Is it more complicated? And so we did a variety of analyses to answer this question. In every case, there is no statistical difference seen between the Barricaid arm and the control arm, including complication rates during the reops. In fact, the complication rate was slightly lower for Barricaid. And all the different revision strategies that you might want to utilize in a discectomy patient are still available to you if you should need to revise a Barricaid patient. And so you can see here these two radiographs, some different fusion approaches that have been used. And you can see that the Barricaid does not necessarily need to be removed in order to use your fusion of choice. Next slide, please. This is a table of the device-related serious adverse events. Overall, a pretty reasonable rate at just over 3%. You can see the different types of adverse events that were reported. Like any pivotal study, our study was designed so that we could learn, and so we can learn about our contraindications and about our labeling. So for example, the anchor migration row, one of those anchor migrations actually occurred in a patient where when they did take the DEXA scan, they saw that the T-score was less than -3.3. So that helped to really reinforce for us why we contraindicate osteoporotic patients. So that's a top-level summary for a randomized control study, but I also wanted to just touch on the fact that we had 6 other distinct patient populations that had been published in the peer-reviewed literature. So each of the rows in this table are publications. You can see that the reherniation and reoperation rates in this table are just as good, if not actually stronger, than what we saw in the randomized control study. Some of these studies were early single-arm studies prior to our randomized control study, but 4 of them were actually studies that our commercial users brought to us. So these are patient registries. We helped to support a data capture system so they could enter the data for both their control patients as well as their Barricaid patients. And it's something we're looking forward to bringing to the United States as well, and working with surgeons such as yourself. But with these additional patient populations, in addition to our RCT patients, we have a robust body of evidence really demonstrating the clinical benefit and safety of the device. With that, I will turn it back to Greg.
So I think that the evidence is actually pretty clear. There's a surprising and somewhat disappointing performance of lumbar discectomy across the entire patient population. Up to 20% of people will need a revision long-term, out 20 years. I think the other thing that is important to realize is that people who have revisions don't do as well as the people who don't need them. So reoperation is not as curative as the primary procedure. And people are often stuck with prolonged disability as a result. So these reoperations are to be avoided. And I think the other thing that's clear now in the data and the over 40 publications on Barricaid is that bone-anchored annular closure has a benefit in this high-risk patient population. It reduces reherniations. As a result, it reduces reoperations. And as a result, it reduces complications and readmissions. These people just do better overall. And that data is clearly statistically significant from 90 days out through 3 years. The 5-year publication is coming up. And to reduce reherniations, to reduce reoperations means something significant both for the patient, but also for society. That if you can do these things, it's going to be cost effective. Actually, there's a great publication that's been put out looking at the cost effectiveness of Barricaid in this high-risk subgroup, and it showed that it was a dominant technology, which meant that it was both providing a better overall clinical outcome at a lower overall cost from a societal standpoint. So that's really what we were hoping to achieve when we started out, and so it's great to see that it bore out in the data. And I think it's the power of the published literature and the sort of overwhelming nature of the clinical evidence supporting the Barricaid in this high-risk subgroup that resulted in a very early determination by CMS for a permanent C code for discectomy plus Barricaid. So we have a really wonderful market access group that is largely responsible for achieving this. But I think in part it was because the data was there to demonstrate that it was so cost effective. So CMS basically said that we were a device intensive procedure from an ASC standpoint, which maximized the reimbursement to the ASC and provided a very healthy outpatient, hospital outpatient reimbursement as well. So we're really happy about that turn of events. On the physician side, CPT coding just takes time, and it takes time, presence in the market, and societal support, and all sorts of things, which are simply going to delay specific coding for the payment of your time, your additional time in addition to the discectomy procedure that you perform. That's going to take until 2023 is what we anticipate, just because of the process with AMA in the United States. So what we're currently requesting that surgeons do is Bill 63030, and this is clearly your decision, and 22899, which is an NOS code. We know that is a difficult code to deal with insurers and payers, but there just isn't a code yet for us. But you still bill for your 63030 or 63042. From a coverage standpoint, we've had really remarkable success. We've just started on the market, and I think with like the first 5 or 6 implants in, we've already got 22 positive coverage decisions around the country. So Blue Cross Blue Shield seems to be very favorable toward us in most markets. We've had a lot of success with workers' comp as well from a coverage standpoint. So we are there to work with you and your mix of payers to argue on behalf of your patients and your office, and to work with your office to make sure that that's as easy as possible during the prior authorization process. We also have started working with a really good patient advocacy group, which supports your patient during any prior authorization process or any appeals process. To date, we have been pleasantly surprised by how quickly prior auths have come through. We were expecting a little bit more resistance, but we've really tried to hone this process through a wonderful group led by a guy named Tom Michael at our company to try to make it as efficient as possible, to make sure that we're ready there to answer the questions that the payer might have, and to work from a top-down approach as well with the payer to convince them in advance that this is a technology that they should support. I wanted to go a little bit more over the technique and the implants so that you could see it in action. It's really pretty simple. The 2 different implant sizes vary only by the width of the medial-lateral width of the occlusion component. They share the same bone anchor. The width, you can see the 8 millimeters on the left and the slightly wider implant, 10 millimeters on the right. So we're indicated for 6 millimeters on up to 10, which is the vast majority of the large annular defects. My preference is if you measure a 6, try the 10, see if the trial gets down there, because I think there's no downside to oversizing. I think my suspicion is that one of the reasons why the single-arm studies post the randomized clinical trial did better is because people started oversizing the implant. So get the largest implant you can get down there. And that's our disposable delivery tool, and it's the same for both implants. This is just to give you a perspective of looking from the back. If you're looking from posterior to anterior, what our mesh and anchor looks like. And so the three main components of this horizontal base plate, that does the majority of the work, this vertical keel that connects that base plate to the head of the anchor. Head of the anchor sits on the target end plate, as close to the target end plate as possible, and it holds the mesh in front of the defect. It's a pretty simple instrument set as well. There's our two alignment trials, 8 and 10 millimeter, the measurement sticks on the lower left-hand side, a nice mallet, and then a retraction wedge. So it doesn't take up much room in the operating room. I wanted to show a quick video. This is a combination of both a surgical case, an actual surgical case, and animation, so you can really get a sense of what's going on. This is a tubular procedure that was done in Australia recently, on the East Coast, and the Gold Coast of Australia. So we do require a little bit more bone removal. Our tool looks small in your hands, but big when you're going through a tube like this. I think this is an 18. This is some of the bone removal to expose the dura and the nerve root clearly. We don't require that you go into the medial facet at all, but we do require a little bit more of the superior lamina to be removed to create the adequate clearance for nerve root retraction and placement of our instruments. Then a limited discectomy, would that they were all that easy. Decompress the nerve root, and then you identify the defect that's there or one that you surgically create in order to pierce the annulus and remove and decompress the nerve. That's our measurement stick. You confirm that you've got the right size and the size of the implant you should use. This is that alignment trial. Remember I mentioned the imaginary line should never cross the end plate. That's where the anchor is going to come out. This is the largest of large of our alignment trials. So you take it, place it down against the back of the target vertebra and on the target end plate. Do the same thing with the delivery tool. Draw that same imaginary line, never cross the end plate. And then you tap with a hammer and you simultaneously drive that anchor into the target vertebra and the mesh into the disc space. Like so. And then remove the delivery tool. And you'll see this on fluoro. 2 millimeters countersunk, mesh is in front of the hole. From the posterior, you'll see that. A little insertion path and the mesh in front of the hole. We are a fluoro-guided procedure, so we do ask that you wear lead during the entire discectomy. I think that's the biggest change. We also, in order to get in plane with the disc, ask you to make the incision a little bit more cranially than you would normally, because you want to be able to target either end plate, either the cranial or the caudal vertebral body. It really doesn't matter whichever is the annular defect is biased toward, or whichever is easier from a nerve root and bone removal from a bone removal sense. So these are 2-year images of one of our patients. The X-ray on the left-hand side, MR in the center, and CT on the right. You can see on the left-hand side the marker against the opposing end plate, 2 millimeters countersunk. MRI, again, clearly see the epidural space and evaluate your neural structures. On the right-hand side, we were required by the FDA to take CTs preoperatively and annually thereafter, just to make sure there was bone integration of the anchor and to judge any migration. One of the very interesting things we saw is that Wolff's Law is in play, and that insertion path. So here's the base plate of the anchor that I described, and this is an axial slice through that base plate, and you see the bone grows over the back of the insertion path actually quite quickly, which is one of the reasons why we had so few migrations of the anchor. It really closes off the posterior wall closes off. I'm going to show just one real quick patient to make a couple of points. This is a 53-year-old female with a really painful left-sided disc herniation. Can't see it as well in the sagittal slice. One of the requirements, this is a clinical trial case, one of the requirements of the FDA was that we have an ODI over 40, which didn't make any sense at the time because this is a leg pain operation, not an ODI disability operation. But as a result, we actually, not this patient, but we had quite a few patients who had significant levels of low back pain as well as leg pain. That's totally okay for our implant. It doesn't seem to have an impact on the performance of our device. As long as the primary problem is a ruptured annulus and nucleus compression in the nerve root, and you've got radiculopathy going down a leg, even if they have high levels of back pain in the ODI, doesn't matter. This is her at 2 years, Barricaid implanted. L5S1 looks like she's beginning to have a little bit of L4-5 problems. These are the 2-year X-rays, AP and lateral. One of the interesting things that we did see, while we do require more bone removal, we did see in almost every case that bone grows back. Again, Wolff's law, the lamina tends to regrow over time, and her pain scores are great. Now, I think you can show a lot of the discectomy, the discectomy only arm of our study, and show similar results, that pain scores at 2 years are great. But really the difference between the two populations was the Barricaid patient population had a much lower reherniation and reoperation rate. The ones who did well did well. The ones who were reoperated didn't do as well, but there were just half as many in the Barricaid group. We did our trial from L1 to S1. I would not encourage you to use Barricaid in L2-3 or maybe in L3-4. So we actually limited our indication from L4 to S1, which is the vast majority of the discs. The reason why it's harder as you go up is the facets move more medially, and it becomes more and more difficult to get our tool down there without damaging the facet. So L4 to S1 is really where we go. 5 millimeters of maintained disc height, tall enough disc, and big enough hole. That's our incident patient population. There are very few exclusion criteria that are abnormal. We don't like big slip, listhesis over grade 1. Discectomy is probably not the right operation for that patient anyway, and no osteoporosis. But otherwise, it's your basic patient population. So that is the end of our prepared introductory